Loud. All right. Welcome, everyone, to our third in the series to look at COVID-19 updates for nurses, hosted by our own Dr. Ruth Carrico, immediate past president of the Kentucky Nurses Association. And today we have some incredible special guests. But before I get to the special guests, I want to encourage you to join us again next Friday for the last in the four-part series of the COVID-19 vaccine update for nurses. So for today, we have Erica Branford, PhD, JD, RN, clinical trainer and coach for Invalon Inc., and Angela Bradford Stevenson, MS, HRD, PHRS. That's a lot of initials in Angela, Senior Human Resources Manager for Beam Suntory, and of course, Nancy Galvani, President and Chief Executive Officer for the Kentucky Hospital Association. Thank you all for joining us today, and we are looking forward to every word that is going to come from your lips. We are expecting about 100 people to join us today, and then afterwards we will put this recording on the YouTube channel for the Kentucky Nurses Association. Dr. Ruth, take us away.
Thank you, Delnor. Thank you to our guests. This is excellent. And I think we're going to have a lot of wonderful discussion about some issues that are contemporary that we are dealing with COVID. Some may say every issue is contemporary since this virus continues to change and challenge us in new ways every day. But right now, today, I want to focus on what is happening in the workforce. We'll look at not only what is happening in the healthcare workforce, but also Angela will be helping us look at what is happening in the non-healthcare workforce and how these situations and activities are all related. So let me start off, Erica. I heard you talking the other night on one of the town hall meetings with Galen College of Nursing, and we had then a number of questions that were asking about legal rights. Since now we have a lot of healthcare and non-healthcare mandates, vaccination mandates, people are saying, well, wait, isn't it my First Amendment right to not be vaccinated? So as an attorney, can you help remind us about the Constitution?
Absolutely. So just as a reminder, you do have First Amendment rights, but those First Amendment rights are freedom of religion, freedom of speech, freedom of press, freedom of assembly, and freedom of petition. So those differ from the overall, anti-vax theory. So the mandate of the vaccination is not a violation of your First Amendment rights. Actually, there is some case law, and I'll just kind of do it historically, if that's okay with you, Ruth.
Sounds good.
Back in 1906, there is a case that is still standing today where there was a smallpox outbreak in Massachusetts, and people 18 and over refused to get that vaccination. So that was taken through the federal courts all the way up to the Supreme Court. And you always have to think about law as the scales of justice. So what is the actual weight? And what the Supreme Court found was that we have an obligation to the people. So it is not a violation of your rights to mandate a vaccine. Most importantly, you can't harm your fellow citizens by refusing a vaccine because you become a disease vector. So that has held the time as a precedent for over 100 years now. The other thing that's really important to remember is in the early 2000s, when we had the university issues with meningitis, we mandated meningitis as well for individuals. So that was an important piece to remember, is that there have been several situations where we've had to mandate a vaccine. The other thing that's really important to remember is that now that the US Food and Drug Administration has fully approved it as of August 23rd, that satisfies, that helps employers be able to mandate the vaccination. The important thing to remember is that employers have the right to set their workplace conditions. And the Federal Equal Employment Opportunity Commission, as well as the Department of Labor, as well as the Justice Department, are saying that corporations have the right to mandate the vaccination. The important piece is that you do have ability to say that you have a medical exemption or a religious exemption. However, it has to be reasonable. And the Equal Opportunity Commission has said that those can be approved, but they cannot constitute an undue hardship for the employer. So I think that's the piece that we leave out, that yes, you can refuse on those two levels, but if it creates an undue hardship for the employer, then that is something that obviously that can't be done. But really what's most important is that mandate that we have really is a public health interest mandate. And this is important because we're in the middle of a pandemic. We don't know if another pandemic will come forward, but we've lost over 600,000 lives. So that definitely makes it a public health risk, a grave risk to workers. And so the Department of Labor has taken action. And I'll let Angela talk a little bit about OSHA and how they'll implement some of the laws. But that's just a basic historical kind of time frame setting the scene for vaccination mandates and the history of vaccination mandates legal.
So that's an excellent review as a reminder that, in public health is our responsibility to care for everyone. Make sure then that healthcare workers are protected, patients are protected, individuals that are in the community are protected, and that we can't pick and choose what population that we want to protect more or less. And so we are seeing then something very similar that is occurring in non-healthcare settings. And Eric, as you mentioned, Angela really has a wealth of knowledge in OSHA that looks at protecting the worker. How are you seeing, Angela, then some of these same requirements for vaccination? What is occurring in the non-healthcare setting? And do you have some insights for us on how we can better understand that and come to grips with the fact that this is not only a healthcare issue, this is a community issue?
Absolutely, absolutely. And to Erica's point, once the FDA did fully approve a vaccine, you're starting to see more and more private companies mandate that. And I think companies are going through a thing of, do we drag people to get to that endpoint or do we bring them along? And so what you've been finding is that you'll have some companies who have said, hey, we're going to mandate this, and this is the due date. And along the way, they've had incentives to get people to do that. Maybe you're entered into a raffle. They've had on-site clinics, vaccination clinics. They've had, cash or monetary things so that people see the value in it. So what you're seeing is you're almost having three sets of groups within that sector, right? Your resistors, as I like to call them, right? Then you have that middle group who could be influenced either way. And then you have that group that's already been vaccinated. And so what you're seeing is a lot of people are trying to focus on that middle group, right? The ones that can go either way. And how do you bring them along, right? And I think the fact that COVID has touched so many people at different levels of their lives, whether there's been a friend, a family member, or someone they've known that has passed away from that, leveraging some of those heartstrings to get people to do that. What you see right now too is, everyone's on the pins and needles waiting for OSHA to give direction after Biden's announcement, because there's a lot of things to consider, right? So you're mandating vaccines. What's the fallout going to be? Are you prepared to lose people who refuse to get the vaccine, right? And how do you replace those people, right? How do you manage the process? So if you think about it, some of the requirements in that mandate is regular testing, right? And so do you offer that on site? So as healthcare facilities, you kind of have a leg up in that way, right? But as more private companies, you're trying to reach out to different organizations. How can we get testing? How can it be readily available? Things like that to consider. I think the other big thing you have to consider is, how do you combine that and all the things that you've already been doing, right? So a lot of companies already have their healthy at work policies and procedures. safety, wearing their masks, social distancing, home health checks. You know, how do you continue to do those things on top of the vaccines? Because we do know that there are breakthrough cases. So at the end of the day, like I said, everyone's on pins and needles waiting for direction there, but also they do recognize the importance of keeping their workplace safe. So whether you're, you know, selling chicken or you in the spirits industry, whatever, you're still providing a service to customers. And, you know, at the end of the day, that does impact your bottom line when you're having to quarantine people, when you're having to go through that cycle of how do we protect our employees. And at the end of the day, that's the number one thing. You know, you want people to come in to work and leave work the same way that they came.
That's excellent. And I think, you know, if we think back to the beginning of the pandemic, you know, back in, I know it seems like a lifetime ago, doesn't it? That we're looking back in late February, early March of 2020. Businesses then quickly began to close. And so healthcare facilities were the ones that were open, learning to coexist with this virus. So very quickly began to develop the safety activities and implement. So for example, we have long had respiratory protection programs in healthcare facilities. We began to ensure then that we were using PPE that was available. PPE that was available, using that correctly. So implementing a number of these programs that really have long been a way of life in healthcare. So we almost have two different sides of this OSHA emergency temporary standard. In healthcare, we have been doing this since the beginning of the pandemic and well before, you know, dealing with other diseases. Now we're seeing then non-healthcare facilities and industries that are trying to figure out how this is going to fit with their workforce. So we, you know, many of us felt like, well, OSHA, you were a little bit late to the dance. You know, we've been doing this for a long time, but non-healthcare facilities have not. So we're seeing that, you know, that kind of tension between the two sides, and then how we can again get to that place where it's safe to be in public, it's safe to be back to work no matter where you are working, and then together we're figuring out how to improve vaccination rates, testing rates, and so forth. Well, Nancy, the Hospital Association has been instrumental in, you know, along this entire pandemic, very early on, figuring out how we can make sure to involve hospitals in testing, looking at how we can protect our healthcare workforce. And I'd love to kind of hear some of your thoughts about not only the where we stand with OSHA, but just what is happening in Kentucky's hospitals, and what are some takeaway messages that we can gain from what you are seeing and your group are seeing.
Thanks, Ruth. Appreciate the partnership with Kentucky Nurses Association. I know our association, your association, and Kentucky Medical Association joined together to release a joint statement around support of the vaccine. So we appreciate that very much. And you're right, we've been on the front lines with our hospitals trying to help navigate this pandemic. Certainly have had a lot of input into the state in terms of guidance for our hospitals, which is good. They listen to us, our nursing staff, our medical officers, in terms of when procedures were shut down, then they were reopened. You know, a lot of the healthcare guidance out there, you know, we've been very involved in providing suggestions to the state. I think where we are now in talking to the hospitals is that this variant has hit the hospitals much harder than the first wave. Mm-hmm. And I think what we're seeing, and if you look at the trend data, you know, at least the first pandemic, it built, but it built on a slower scale. Whereas this, it like skyrocketed. The cases just came all at once. And unfortunately, you know, we've always had a staffing issue in our state. We could always use more staff, especially frontline staff. But early in the summer, I was hearing from the hospitals that they were very worried if we did have another surge, because they said, I don't know how we're going to staff, because we've lost people from the first wave. We've lost people who have retired. And of course, a lot of us are at that age where we could retire. And so people are doing that. We have other staff that said, I didn't sign up for this. I'm not going to do this anymore. Maybe they were not even in the profession anymore. And so we were already short-staffed when this wave hit. And so as a result of that, we just can't staff all the beds. And so our hospitals report daily, on weekends, holidays, you name it. They report over 200 data points to the federal government, and they report such things as, where they are with staffing, on their ICU beds or med-surg beds. Are they have a critical need? Do they have a critical need today? Do you have a critical need coming in the next week? And we are I don't know. Today, some people thought maybe we've peaked, but it's very bad. We talked to our hospitals across the state, and what they're telling us is that they've never had their capacity so high, but the constraint is we can't staff all of our beds. There's about 30% of our licensed beds in the state that we cannot staff. We don't have the staff to open them. And so that's a problem when we're being overwhelmed with COVID patients, because there's very little ICU capacity. And we look at this daily, and I'll just give you a feel for that. Within the last 3 weeks, even though our hospitals, of course, you can always create more capacity, but you can only create what you can staff. Our hospitals added over 200 licensed or 200 ICU beds in the last 3 weeks, but we have less ICU beds open. It dropped from 10% 3 weeks ago. It was only 7% a few days ago, and that's because the beds are being filled as fast as we can open beds. And so that's quite a concern, especially for people that need to get in an ICU for a non-COVID condition, a heart attack or something like that. So we're very concerned. We've seen really bad studies out of other states where, people are dying because, they can't find a bed. Now, I don't think that's happened here yet, and we are hoping that it doesn't happen. But, staffing is certainly a concern. And it was a concern, I think, that factored into the decision for hospitals that move forward to require the vaccine as part of their vaccine policy. And so I guess that was back in August. We had 53 hospitals basically that announced a vaccine mandate. And but they are large systems. They cover actually 72% of all the acute care beds in the state. And, they did that for a number of reasons. And kind of to the point that was just made, we want to make sure our patients are protected. You don't want a patient to come in and they don't have COVID and they leave with it. We certainly want them to be better when they leave. We know, you have to be sick to get in a hospital. You have to be really sick because, of course, insurance companies won't let anybody in unless, they're very, very ill. So we have compromised patients that we certainly don't want to spread COVID to. Also, I think the FDA coming out and approving the vaccine made our hospitals feel better about adding that requirement. But as you all know, hospitals have other requirements for vaccines, flu vaccine. And so they felt like this made sense, to add this on. Of course, they allow for exceptions, as was mentioned, the medical and the religious exceptions. But, they also, staffing played into this, because as we talk to hospitals across the state, what we hear is, X number of staff are off because they're unvaccinated, they had an exposure, somebody in their household was exposed, they're in quarantine, they're in isolation. So the fact that, they have, and it's a large number of staff, oftentimes in some of these hospitals, how are they going to be able to provide care when their staff are off in quarantine? So that certainly played into it. Now, a number of hospitals had the date was September 15th for many to either file for an exception or move towards getting the first shot. And what I'm hearing is that most staff are coming around. We are not hearing about large numbers of staff resigning or anything like that. We think, many of them, the majority is what it sounds like, are getting the vaccine, and that there's no operational problem. And I think that was a misconception. Of course, we just came out of a special session, and we were trying to get financial relief for hospitals to be able to pay their workers more. We know that the nurses are on the front lines, and we know the nurses are exhausted. And so we wanted to, be able to provide incentives for them. And we were asking our state legislature to provide some funding from federal funds that they've received. And unfortunately, I think there was a misconception that the hospitals requiring the vaccine was causing the staffing shortage, which was totally not correct. So we are going to continue to push for that. We are testifying very frequently to the legislature, even though they're out of special session, they are having regular meetings, and we're going to continue to explain to them that our hospitals are constrained. Just a few days ago, I was talking about that that survey that the hospitals filled out, and 60% of our hospitals reported that they had a critical staffing shortage. And I just saw a national map come out, and we were like the worst state. So, we obviously have a need for financial assistance, and we want to be able to support our nurses that are on the front line. And we know, they're being asked to, work longer hours, take additional shifts, and, we just want to support them.
Yeah, I think, Nancy, you brought up so many vital points. And that is, first of all, recognizing that each one of us is 5 minutes away from needing to be on the other side of that bed rail. So this is not a problem that impacts somebody else. This is all of us. And that it is vital that we protect our healthcare workers, our nurses, so they can come back to work tomorrow. But also thinking beyond tomorrow and even beyond next week. And that is, how do we retain healthcare workers? How do we retain nurses? And how do we recruit people to enter into a profession? So those people that are going to enter, or that we hope to enter into the health professions tomorrow, are going to be looking very closely at how we are protecting those that are in those professions today. So, the type of message, and I know, Delano, I want to kind of get some comments from you. I know you have been working with the American Nurses Association and other national organizations to look at what does recruitment and retention look like. What are some of those challenges, some of those thoughts, what do we need to be considering? I know we have a number of those that are in faculty and in some of our educational, some of our academic institutions across the state. What are some of the things that you have to share regarding some of those conversations, and maybe some of your personal thoughts?
Thank you, Ruth. I appreciate being included in this conversation, because we're pulling together a group of healthcare leaders, including nursing leaders, next week to have that dialogue, because recruitment and retention is huge. We are losing a large number of nurses to out-of-state travel nurse agencies, and they're getting paid a huge amount of money. So looking at what do we need to encourage nurses to stay local, to support their local communities. What types of things do we need to do to encourage that? Another thing that we're looking at is doing a quick survey to send out to all the nurses in the state to say, okay, if we had a magic wand, knowing that we cannot make nurses in the basement, what could we do to help you to stay local? And so we're asking those questions. And so some of the things that we're hearing nationally and from the American Nurses Association include things like just saying thank you to nurses. And that is not a donut. That is actually saying thank you. Wearing a mask when you're inside. I mean, so coming up with a list of things that people can do that say, nurses, we see you, we hear you, we appreciate you, and we appreciate you showing up to work to take care of my loved one. And so the KNA is planning to bring those people together to the table to hear from them, to see what they're already doing that others might capture and do, and then also to brainstorm what we can do as healthcare providers for the state. So it's in motion, and we have also been invited to speak at the Health and Welfare Committee meeting next week. And I imagine, Nancy, that you will be there as well. Well, we have not typically been invited. I got notification of that at about 7:45 this morning, so I'm pretty excited. We will be there with you to share our information from the nursing perspective, because a lot of the decisions that are being made impact nurses as well as other providers. So I want to get to a couple of questions. We only have 5 minutes left, Ruth. Would that be okay with you?
Please do.
All right, thank you. Okay, one of the questions has to do with why are LPNs not tapped as nursing resources in the hospitals? I know that many hospitals are magnet and want RN, BSN, but it seems we have resources for staffing not being used. And I'm going to ask Nancy if she might want to take that one. And when you finish with that, I have something to add.
Yes, absolutely. And you're right. Some of our hospitals were sort of focused on BSN, but I think that attitude is changing. We have already begun discussions among our members about how are we going to staff in the future. And we have had many of our large hospitals say, it can't just be BSN. Certainly there's a role for that, but we need to have all levels within the facility. And so we are starting actually we're going to have a workforce committee at our association that their first job is to look at nursing workforce and, think about, how do we maybe need to reimagine education? How can we get people in the pipeline? How can we assure graduation, that we have competent people coming out of the schools? I mean, we're going to look at everything, but that is definitely part of it.
On the table for this group that's going to be coming together next week is looking at different practice models. And as Ruth knows, and she has some great ideas about practice models going forward, we may have to look backwards at some of those practice models we had in the past to see what we can do in a hybrid or a blended model for practice. Okay.
I think too, I know, Delano, we have really been working to engage through the affiliates program, then multiple groups. And I know that that I would love to see some of our LPN colleagues that to help us then identify the best way to pull in then as part of our collaborative activities. The LPN some of the formal groups that can help us then communicate more effectively, engage more fully, because sometimes we're hobbled in being able to get then people to the table that can help us then, reach then a broader population for all nurses. So this would be great. I would love to see then some help in us being able to do that.
Well, as I said, we have quite a few questions in the chat box here, but I'm going to ask this one of you, Ruth, because it has to do with boosters. And, there are a lot of people out there who want those boosters and they want them now. Can you tell us a little bit about what is the current thought about boosters?
Sure. So I think in a nutshell, we have two different groups. We have a group that are considered to be immunocompromised. These are the groups that probably 2 doses weren't effective in getting their antibody levels up to that kind of home run a level. Those are the people that we are pushing where we already have guidance regarding a 3rd dose. So that is already good. People can walk into a pharmacy anywhere. There are kind of a checklist approach of sorts for people that will say, yes, I'm on a drug that suppresses my immune system. I have an underlying immunosuppressing health condition, and then you'll be able then to get that 3rd dose. For healthcare workers, or those of us that are immune competent, who have received then a full series, either 2 doses of the messenger RNA vaccines or 1 dose of the J&J vaccine. We are expecting some guidance from the FDA and CDC, perhaps as early as next week, that will help us say, all right, these are the targeted groups for getting a booster. Now, a booster means that the first 2 doses of the mRNA or the 1 dose of Johnson & Johnson got us to a sufficient level of antibody, but over time, those antibody levels have decreased, so they have waned. We would then be in that target group for receiving a booster within the outlines or the constraints of those recommendations. So we should know more. There have been a number of discussions with hospitals, pharmacies, long-term care facilities about our capacity to provide then those booster doses to healthcare workers. So I know more is going on now, and so stay tuned. There should be more updates on that, but booster doses we expect will be coming soon. So be prepared to roll up your sleeve again and bring out dust off your your COVID vaccine card so we can write third dose on there. But we expect that to happen fairly shortly.
Okay, we are at time. As you said, Erica, the 30 minutes would be packed and it would go fast. It did. So I want to say thank you, Dr. Ruth, for leading and hosting this discussion. Thank you, Nancy, for being with us. Thank you, Erica and Angela. And we look forward to seeing you all next week. Same time, same place, 1 o'clock on the 24th. Also want to encourage all of you to attend the mental health support for nurses and other healthcare workers in the form of the clinic. And you can get that information on the KNA website. Thank you all for being with us. We'll see you again
Excellent.
next week.
Very good. Great. Thank you all so much.